So, as I just spoke about why we chose the topic, that is the prime reason why we would be discussing why this kind of a this kind of a non-specific topic has been taken up. So, at the end of this session, I think most of the listeners would be able to understand and probably care for patients in a measure why how it has to be. Mostly, what are the most most commonly seen chronic lung diseases? So, to start with, many of the patients will have allergic issues, which can last for their life. Asthma, allergy, these are the common things. The other, once patient reaches middle age and who have been smoking, those people are at a risk for chronic obstructive pulmonary disease. Uh, other, the other spectrum of the diseases are interstitial lung diseases, so which can happen even few of them can happen in the early age, like hypersensitivity pneumonitis, or they can happen in the middle age, like sarcoidosis, and few of them can happen in the at the later stage of the person's life, which can be like interstitial pulmonary fibrosis or non-specific interstitial pneumonitis, and this goes on. So I would say approximately 60 to 70% of the lung diseases what we see are of chronic in nature. So that is one of the important things we have to note. So it is not just like we just treat them for the current reason why they're coming. We also have to have the background of the patient appropriate. So that's why it becomes important to have a proper evaluation. And considering this and treating our Indian patients with at least most of our patients who come to us, especially from rural or semi-urban population, would it would be very difficult for us to make them educate about their condition. So it is an extra stress and extra time for the treating physician to understand this. And as I said you, the treatment would be entirely different. One of the important topics what I would want to be touching upon now is pulmonary rehab. See, as we see what are the different chronic lung diseases, COPD, asthma, bronchiectasis, all these are related to the airway. Interstitial lung diseases, just as we said, as I said you. So post-infective sequelae, it could be earlier we used to see most of post-infective sequelae of tuberculosis. A patient would have a fibrothorax and that would run for his life. He had to sustain with that kind of a life or that kind of a lung for his rest of the lung. So all these chronic lung diseases can eventually lead to respiratory failure, chronic respiratory failure. So it is type 1, it could be type 1 and type 2 as well. Some patients would have problem with only in oxygenation, which is called as a hypoxemic failure. Other patients would also have a pump failure, which will be called as type 2 failure, where they start retaining carbon dioxide as well. So new block on the kid now, because all these last 10, 20 years, obstructive sleep apnea was not so very well uh, addressed or seen. So now with the advent of new diagnostics, with the advent of lot of research and lot of papers coming out on obstructive sleep apnea, it has become an important disease. It is actually called we could call it as a hypertension or diabetes of a in a lung patient. So that's how it is. It's a very chronic disease which goes unnoticed, like how diabetes and hypertension were in the community, say for about 30, 40 years back, with nobody very well aware of this, and how and when you see now how impactful these diseases have been in our day-to-day lives, as you can see in the entire world, that kind of an impact obstructive sleep apnea is currently having. So allergic rhinitis, though the name sounds very very small, this is I this is one of the most important causes of disability associated life years. It ranks amongst top 5 conditions in terms of causing disability associated life years. So a new now newly after COVID, we had a significant number of post-COVID fibrosis and sequelae. Few people labeled it as long COVID as well. By now, you would have understood what these diseases can be and how well these have to be tackled up. The next slide, please. So evaluation of such patients is not so easy. We need to spend good amount of time with them initially. The best thing would be to still follow the same measures as we do in our routine practice. So first, ask the patients to give their presenting complaint. You would have noticed in your clinics most of the times, or if there are many students around, so most of the clinics, patients who present to us, they will, the first line they tell is, sir, I will tell from the beginning. Then he'll 20 years back, 30 years back, history starts from there. We have to cut it down initially. We have to tell them that, oh, okay, we'll listen to that later. But firstly, what we want from you is, what is the current reason which brings you here? So this has to be important. Presenting complaint, when you when you are when you ensure that the presenting complaints are reasonable and you have sufficient time to take the next history, then we'll have to definitely assess for the chronicity of the condition. Suppose I'll take COPD, basically asthma as an example when I describe all these things. So a person during his childhood, say a 30, 40-year-old person now comes to you and says that he is breathless. When you ask him for chronicity, he says that yes, I have had earlier, but it would not be so impactful. Every now and then I would have wheezing cough, but it would go on its own. So there should be a stress on eliciting the history. We have to properly assess it. When was the earlier history and all those things. Second thing, we have to look for the frequency of the symptoms. We have to ensure that how frequently, get to know how frequently a particular patient would have had these symptoms in the past, and of late has the frequency or intensity of the problem increased. Likewise, severity of the illness. Has the asthma been severe all throughout, or is it happening in phases? And we also should understand if there are any aggravating or relieving factors. So mostly patients of airway disease, the aggravating factors would be climate, exposure to dust, exposure to allergens and all that. Relieving factors when they are away from these conditions, or when their health is very optimal, in the sense they are able to exercise daily. Good amount of exercise can, especially in young ages, can relieve all these symptoms and associated symptoms. So why I tell associated symptoms is, eventually most of the patients who have pulmonary long-term pulmonary diseases would invariably develop some amount of cor pulmonale, if not cor pulmonale, at least pulmonary hypertension, which again is a single independent risk factor for the patient's longevity. And many a times we may not be able to find the exact etiology, but at least we should work to get if there are any evident etiological factors present. So next slide. So once the subjective evaluation is done, then we have to have a proper objective assessment. So most of the times in with respect to pulmonology, the objective assessment can happen in three, four ways in different dynamics. So one of them is imaging, which can be easy and done on every patient. It is not a tough thing to do. We can do a CT scan in most breathless patients as well, more often than not. So secondly, we have to also look for their effort tolerance. The basic method of evaluation of effort tolerance is by doing a 6-minute walk test. I hope most of you are aware of what a 6-minute walk test would be. It is the simplest form of cardiopulmonary exercise testing. We ask the patients to walk for 6 minutes. Prior to the walk, we would have recorded their baseline vitals, and we would also have had their breathlessness in terms of BOG scale, which is a visual analog scale between 0 to 10. If a patient is not breathless at all, we grade it as 0. If the patient is extremely breathless, it would be graded as 10. Those uh, pre-test pre-test chartings would be noted down, and the patient would be encouraged to walk for 6 minutes. So in between, if the patient wants to rest, he can rest because it is the simplest form of exercise testing. At the end of the test, what becomes important is what is the amount of distance walked and how are his vitals later. A person might have walked 300, 400 meters, his saturation would also have not dropped, but the heart rate would have increased. So this itself, if there is a significant heart increase in the heart rate, that itself can tell us that the patient is having some amount of significant cardiopulmonary compromise. So apart from this, we also have to look for the patient's objective evaluation regarding how the patient can use different modes of medication. So what medications can he be put on, and whether he'll be needing a nebulization or an inhaler. Would he also require a supplemental oxygen? Would he also require a non-invasive ventilatory support? All these have to be assessed for. So to assess for the effort of the patient with respect to cardiopulmonary thing, we have the 6 minute walk test, and with again in terms of purely measuring the lung capacities, we have to depend on pulmonary function test, which I think most of you would be aware of. It is a blowing test where the patient has to blow in a specific manner into a device, so through which we mainly get to know the patient post expiratory volume of the first second, which is called as FEV1, and post expiratory volume of the first second upon forced vital capacity. So this is the ratio, which is an again an important factor. The third one would be post vital capacity, which is again the denominator in the previous fraction, which is